Welcome, everyone. Welcome to the Ontario NEIHR Webinar Series 2023. Today, I would like to introduce Dr. Janet Smylie. A Métis woman, Dr. Smylie acknowledges her family, teachers, and lodge. Dr. Smylie is a family physician and public health researcher. She currently works as a research scientist in Indigenous health at St. Michael's Hospital, Le Caching Knowledge Institute, where she directs the Wellbeing House Applied Research Center. Now I would like to pass it on to knowledge keeper Clayton Shirt. Clay?
Thank you, Roy. Good afternoon, my relatives. Happy New Year to everyone. It's been a challenging couple of years for everyone, for all of us, the human beings, and I just want to acknowledge that and just say an opening prayer. Traditionally, we'd be together in a circle. This would be a great, a big circle, a ceremony, and this is my part of my role at Wapabanez as a traditional knowledge holder / keeper / elder. I don't consider myself an elder, just a practitioner of my spiritual beliefs, my traditions, my culture. So I'm going to try to do this traditional opening on Zoom. I've had a few years to learn how to do this on Zoom, so I think I'm okay with it now. But I just want to paint this picture. It was very uncomfortable for me at first, because when we like to get together in a circle and we like to use our medicines and smudge and invite spirit into that circle, into that, it is a ceremony. And as to me, research is ceremony. Ceremony is research, right? So all of these things. So I'm going to say an opening prayer and invite spirit in wherever you are, and we're all together. And I want to thank everybody for coming today and spending the afternoon with us. And so I'm going to say this prayer in this language. I don't speak my language that well, right? So I'm just going to, I'd like to start with acknowledge, and I want to say miigwech. I say thank you. I like to say thank you to our first mother of all mothers. Again, we come together as the people, the human beings, and we say thank you to her. Our first mother of all mothers, our mother the earth, for providing the medicines to sustain life, to have a good life, and all the things she does for us. Again, I pray to her. Again, I pray for her in gratitude. We come together as the people to acknowledge this and say in gratitude for everything she provides for us. It has been challenging lately in the last few years. And I say thank you to our mother for giving those medicines and always giving those medicines for us to stay well and healthy, those sacred medicines, that sema that we offer to her in gratitude, that sweet grass we smudge and clear our minds with, that sage we purify our minds, our bodies, our spirits, that cedar that we cleanse ourselves, to heal ourselves, to wash ourselves. We give thanks to her for providing these things and many other medicines from all over the world that she gives to us to sustain this gift called life. Again, I love you. I say miigwech from my heart of hearts. I offer my prayers to Father Sky. Again, I ask the spirits of my ancestors, your ancestors, those kind, loving ancestors who are always behind us, guiding us, praying for us, being with us, those loving ancestors, those good ones. I ask them to bless you, to bless me, my children, my loved ones, your loved ones, in these very difficult, challenging times. Give us strength to keep going as the people. We come together, acknowledge this. Father Sky, our ancestors, that spirit world. Again, we say thank you for being with us. All my relations, I offer my prayers to the sun, grandfather of all grandfathers. You are so beautiful, you bring light. We bring warmth for everything to grow, for us to sustain life, and many other things you do for us, grandfather, son. I give thanks for this day, wherever we are today, for a new day, a new beginning. And if I have done anything wrong in the past, I have this moment, I have this day to make it right. And I am grateful for this, for a new day, a new beginning for all of us. I thank you, grandfather, for doing this, for giving the appearance of rising in that sacred doorway, that eastern doorway, for bringing the light, for bringing the warmth. I say thank you, grandfather, son, all my relations. I offer my prayers to you, Nokomis, grandmother of all grandmothers. I humble myself. I pray to you. I pray for you in gratitude for everything you do for us. I love you. I send my prayers to you. Grandma Moon, you are so beautiful in the night. You bring light to the night and many other things to do for us. As a man, I acknowledge this. You bring order. You put the waters, the rivers, the lakes, the oceans into order for us. For we acknowledge this, for water is life, and the gift you do this. And I love you for this, Grandma Moon, and many other things you do for us. For water is life. I say thank you, Nokomis. Again, I pray to you, I pray for you in gratitude, for my heart of hearts. I love you, I say miigwech to you, Grandma Moon. I offer my prayers to you, Creator, great mystery. I humble myself. I ask for the blessings for our speaker today and her family and her loved ones and all the people who have come here to work for the people, work so hard for the people, who've worked so hard in these difficult, challenging times. I ask to give them strength and guidance, to give our speaker today the strength and knowledge and the guidance to keep going. I say thank you, Creator, for bringing us together in this virtual circle. I say thank you, Creator, for the beautiful gift called life. All my relations. Miigwech. Thank you for allowing me to say that simple prayer that I try and desperately try to live by every day of my life. And I fail miserably at it. But that's the whole point, is to keep going. And our speaker today is a good friend of mine. And I just want to say thank you, Janet, for I know you're supposed to say this after, but I just want to say thank you for all the work you do for our people. Miigwech.
Hi. Nana Sumitin Clayton, for that beautiful, for the beautiful work that you do for the people, which is such an important role and responsibility that we take up to help us by providing a spiritual foundation for us and supporting continuity of our spiritual tradition. We'll say Tenzi Italia, Katia, Kitan, Skatanawa. So hopefully there's some people there that are a little bit more fluent in Cree than me. But I just said greetings everyone. I greet you all in a good way. Yeah, my grandmother, my maternal grandmother, was the last fluent Y dialect speaker in my kin line. So I make a point of trying to revitalize the language, even if sometimes my tongue stumbles a little bit. So I wanted to, in addition to acknowledging Clayton, and just to note how wonderful it is when I heard you the opening and closing, and how beautiful it is because we have known each other for a while. And also we have some relatives, some shared relatives, and the circles that surround us, there's some interconnections, and that's so powerful. Also, just to commend Roy and give my thanks, because he's amazing. And it can be tricky sometimes to track people down and organize them and get 52 people to come to a webinar. And then just to acknowledge the leadership of the Ontario NEIHR, my friend and colleague, Dr. Suzanne Stewart, and each and every one of you that has come here today. So I'm going to tell some stories. It will be a little bit of talking, but actually, and I'm going to start by a self-location, and it'll be a longer one than usual, but there is a lot of chaos and confusion around First Nations, Inuit, and Metis identity, a lot of pretendians out there. So I will self-locate. Then right after that, though, hopefully within about 5 or 10 minutes, I'm gonna ask you some questions. So it's a kind of simple version of learning from stories, right? Because this is just one story. These are going to be my stories. And I think what's really important when we try to build and exchange knowledge together, and we have these funny new tools, right, like Zoom, which don't necessarily allow us to engage in energy exchange in the same way when we do it in person, but we'll try our best. So I'm going to encourage people to listen actively, think about what resonates, what doesn't resonate, and think about what piece of the puzzle you hold, because I only hold a little piece of the puzzle. And then hopefully we'll have a little bit of time for discussion after, but feel free to use the chat. So I have something called a Tier 1 Canada Research Chair in Advancing Generative Health Services for Indigenous Populations in Canada. So that's what I'm going to tell my stories about today. Really hoping, because for some reason, when we started, so where I am just having a little bit of trouble advancing my slides now, and I'm not sure why. Oh, there we go. Okay, so I said I would start with a self-location. So for me, I think it's really important for First Nations, Inuit, Metis, Indigenous nations, local Indigenous groups to come up with their own self-determined definitions of what it means to be them, the people, in their languages and specific locally rooted paradigms. But broadly, when I speak about this, to me, it's about my relationships. It's about my relationships with land over time, and my relationships with people, my kin lines, and my kinscape. And in fact, relationships with all things. So I just wanted to share some land. So I'm actually here in Ottawa, and I said it's going to be a bit of a storytelling kitchen table session. I'm in between. So I'm actually in the lounge at the Ottawa airport, so traditional territories of the Algonquin people. And you'll hear some little noise in the background, but just pretend then you're at we're in a coffee shop in my kitchen table, and maybe someone cooks in the kitchen. And yeah, if for some reason there's too much background noise, maybe where you can just like jump in somehow magically into the Zoom and let me know, and I'll see what I can do. I think I'm implied in front of the lounge. But where I actually live in Takaronto, homeland, traditional territory of the Haudenosaunee, Huron, Wendat, and Anishinaabe, and Mississaugas of the New Credit, actually, we're just right in my partner's treaty territory. My wife, Nancy Cooper, who's from Rama. So, yeah, Woodbine Avenue is like a treaty line, actually. But my wife and her family actually have repatriated 300 acres of traditional territory just south of Minden. So that first picture is me being on the land in the fall, and we actually had an opportunity to work together with another Anishinaabe family to do some beaver harvesting. And it's interesting because actually a colleague of mine, one of the stories I'll talk about, some of you know I spend a fair bit of time thinking about information systems that actually can support sharing information from an Indigenous perspective of what we know about the health of all of our people, including the ones who sometimes aren't well connected or don't come into the clinic. but actually some colleagues that I just had the opportunity to visit at the Aboriginal and Torres Strait Islander Research Centre at the Australian National University in Canberra, Dr. Ray Lovett, they have a paper now published in the Lancet where it actually talks about not only how racism in our current day interferes with our mental health, but some of their other findings, I don't know if they published it, but they shared it at a webinar earlier last year, was about how being on the land actually improves our mental health. But I think about the land in my backyard too, but there's a piece of land that I have an ongoing relationship with in Ontario. I actually spent a lot of time as a child every summer on the lakes of, on the shores of Lake Timiskaming. The other picture is a picture of the Saskatchewan River. So here you'll see my maternal kin lines are like rooted and unbroken to the prairies, Red River, and Treaty 6, but then into Saskatchewan and Saskatoon. In fact, my mom grew up and my grandmother spent most of her life in Saskatoon. But here we have the Saskatchewan River, and this is an area known as Gabriel's Crossing, and it's actually where Gabriel Dumont had his ferry crossing. So that ceremony lodge I talked about is a grandmother's lodge, and this is a picture of the land around Gabriel's Crossing. I know it quite well because I've had the opportunity, the extreme privilege of sitting on this land fasting for many, many days, weeks, and years. So, and here's my maternal kin line. And again, it's interesting because what it means to be Métis in Ontario, and how we're related as Métis to First Nations people, to me is very different. Sometimes the things that I hear consistently, especially at the university, than the actual history and what it actually means in Métis community in the prairies, to be Métis and our relationships with First Nations. And I worry, I trouble, and you'll hear in these stories, I continuously trouble this externally imposed siloing, because of course lots of this comes from the Indian Act, and of course there was a purposeful attempt to segregate First Nations and Métis people, even though we're related. So it's not to conflate or undermine treaty rights, but it's just actually to talk about who we really are and who we're related to. So there's my mom Metis's graduation picture. So she trained as a nurse actually in Saskatoon with the nuns at St. Paul's Hospital. Interestingly enough, now I'm a doctor at a Catholic hospital called St. Mike's that was also started by nuns. She was a really talented nurse actually, and she moved from Saskatoon to Toronto in the late 50s. She graduated in the early mid-50s, 1950s, and that's how she met my dad. And that's how I ended up being a visitor in this territory, but then being able to build relationships with my dad's family territory and also my partner's territory. There's my grandmother, Ruby. So Mavis Whitford, Ruby was born Ruby Whitford. Ruby lived until she was 82 in Saskatoon. She was born in a road allowance for a very small Métis community called Phillips, Alberta. It doesn't exist anymore. So just so people understand too, because often people are applying like a reserve lens to Métis people, but just to say that most of us have been dislocated and pushed into urban environments. Though of course we do have some settlements. And then there's Ruby's grandmother, Marguerite Sauvé. So that's how I'm related to Alida Sauvé. And you'll see later on in the talk a little bit about how actually my direct maternal kin line then, and Ruby would have grown up speaking Y dialect Cree because we go into Treaty 6 territory. Just to own that I'm mixed. I'm mixed not because I'm Métis, because Métis are not mixed people. And please don't say that because it's actually, many of us will actually perceive that as a misunderstanding or insult. But I'm mixed because my dad, Douglas Edwin Smylie, is of white European ancestry, Irish, Scottish, and English. So there's a picture of my dad, and some of you know he actually was a university professor. So in some ways, with a mom who was a Métis nurse and a dad who was a settler theoretical physicist, I come at this interest and perhaps some aptitude for health research, honestly. What do we mean by setting a generative course? The word generative actually is around in white streams, so it's used in business a little bit. Some developmental psychologists, excluding Erickson, used it in the 1970s actually to talk about like midlife. But my favorite definition was gifted to me by one of these elders here. So this is just a picture of a mural by Christy Belcourt, which is a beautiful mural that's actually owned by 7th Generation Midwives Toronto. And Christy allows us at Wellbeing House to use it. You know that our logo on these slides then is derived from that. And 3 of our founding grandparents at Wellbeing House, Madeline, Dion Stout, Jan Longboat, and Carol Terry. So Madeline gifted us and reminded us about this tremendous getastuin, which means attachment through the ages where all people and things are connected. And I alluded to this, and this is really probably one of the most foundational teachings for myself and my family, this idea of building Wakotuin and relationships. And yeah, it's actually something that I love to think about in a health service context. What is health services for First Nations, Inuit, and Metis people across the nation, or Indigenous people around the globe, actually enhance attachment through the ages where all people and things are connected? And you went to see your family doctor. That's why I love Indigenous midwifery as a health service model, because I think it does that. If we had attachment through the ages where all people and things are connected, I don't think we'd have any global warming. I don't think we'd have any wars. Okay. So if we're trying to think about how to build generative health services, how to decolonize like Indigenous health and public health, I guess there's kind of 2 approaches. So I popped up this slide when I was an expert witness at the National Inquiry for Missing and Murdered Indigenous Women, Girls, and Two-Spirit People. I went back to my ceremony lodge, my elder Mary Campbell, and some of the lodge members, and said, well, what should I say? And they said, well, why don't you start talking about something positive, right? So I put up this slide about these 2 approaches. So approach A, dig into what is wrong with colonial systems and within our own communities that has been internalized, fight to change them. Or the answers lie in our communities, in our stories, in our lived environments, and in our government. So I think we need both of those things, but I just wanted to lay them out there because I think it is helpful to think about what we're doing. So today's 4 stories, and I might have to tell them pretty quickly. The first story and the first couple stories really are about rooting out racism and colonial approaches. And the first one is going to be sharing some results about a research study that we recently completed, a randomized controlled trial where we were able to, sorry, just a little bit of background noise there, but doing my best. Yes, maybe some people, there's a free lunch buffet, so maybe it's turning into a bit of a wild cafe. So in Reconciling Relationships, a 3-arm randomized controlled trial where we actually piloted some new tools to evaluate cultural safety training. And they were kind of people-focused, patient-focused. The second story is more at a systems level and just expresses some of my concerns about how siloed health information systems are actually harming our people and dividing us. And of course, that's what the Indian Act did, contributed to apartheid in South Africa. So remember, apartheid in South Africa had multiple castes of people. So the old divide and conquer. And then 2 stories then that take the second approach and talk about how the answers lie in our community. So many of you have heard about our health council. Share a little bit about how we were able to pivot that project to produce otherwise unavailable data about basic COVID information for First Nations, Inuit, and Métis living in cities. And then the final one is my very favorite story, the story about the Toronto Birth Centre. And I love that story, right? Because it's an Indigenous-led, Indigenous-governed model that actually advances health for all. So here's your homework for the next 15 or 20 minutes while I'm talking. What I'm hoping you can do is reflect on the stories. And again, I think if this was a really good learning thing, maybe we would be in a room in ceremony the way I've seen like some of my elders and teachers set things up. There would be a panel of people telling a story about a thing. So you would get more than just my perspective. But then you would be encouraged, and I've sat there and I was encouraged to actually think hard on what the teachings are in the stories, and then what do I bring? So often in my lodge, in our ceremony lodge, there's a whole bunch of different Indigenous scholars, Métis and First Nations scholars, many artists, lawyers, historians, there's midwives, but I'm the only physician, so I'm supposed to try to bring that perspective to the work. So I hope you can do that. Okay, so story number 1, interrupting anti-Indigenous racism in healthcare. And of course, we need to do this at the systems level, and we need to do it at the patient level. And some of you know, this is the first kind of scholarly thing, if you call it scholarly, or that thing I've been working on. So I published a guideline in 2000, actually. If you ever come across it, be gentle. It was my first piece of writing. One thing I think I did well was I actually had an amazing set of supporting organizations and special contributors. And then, of course, the idea of cultural safety, again, like in 2002, Ira Petty-Ramsden published her thesis on cultural safety. So people have been at this for a little while. What could we do so that healthcare professionals, settler healthcare professionals, actually are better equipped to provide health services to First Nations, Inuit, and Métis people that are of high quality, so they meet or exceed quality standards, both with respect to clinical care, but also relationally. And one thing that's interesting is you can actually then see on this Medline search. So I did this Medline search in August. I just put in cultural safety training. So you can actually see an exponential growth curve if you look at that curve on the side, the one that starts at 1956 to 2002, right? So this is a high growth area. Everybody's setting up cultural safety trainings, so they're growing exponentially. So my job as a researcher, and what I'm particularly interested in is, so what? And I was trained by the grandparents. I would present this great study, and I can remember Jan Longo one time we were doing some the story medicine study. I can talk about that a different time. And she said, well, so what's happened? Like, are people less depressed now? Are they feeling better? Right? So what's happened with this exponential growth in cultural safety, right? And what has happened? Has anything happened since Brian Sinclair died in the emergency room, since Joyce Echaquan died? Like, is things better at my hospital at St. Mike's now? And my worry is, I don't think so yet, right? So what I really want to understand, because one thing that, and so thanks to Dr. Billy Joe Hardy, many of you know, we're actually just in the process of finalizing and submitting international systematic review on Indigenous cultural safety training focused for practicing healthcare professionals. And actually what we've found, the story here is that the outcomes are very learner focused. And of course, in educational research, and oftentimes in education, when my sons go to high school, they're the beneficiaries of the education. So they should be learner focused outcomes. But in medicine and in healthcare, actually, of course, we need to engage the healthcare professionals, but the beneficiaries actually are the First Nations, Inuit, and Métis and Indigenous health service users. So it just seems a little odd when we dig into this that the outcomes are all learner focused. Seems a little suspicious, because somebody could go to a cultural safety training and feel really great and think they're really good, and actually they might actually be more dangerous than before the training. And one of the things, if we examine the pedagogy, which I've done, I actually think that cultural safety training usually, if it's working, I think settler healthcare providers should feel quite uncomfortable. You want to engage them in a good way so they can sit with that discomfort and learn. Because I actually don't think most people go into healthcare because they want to help people. So it should be unsettling, pun intended, to realize that you have implicit bias and it translates into unequal treatment. So we were very interested in trying to figure out, okay, what's the so what of this cultural safety training? And can we come up with some measurement tools that can actually help us understand person-centered outcomes, the recipients, the beneficiaries? So the impacts on First Nations, Inuit, and Metis service users. Amazing team. I mentioned Dr. Billy Joe Hardy as well, Sam Filipenko, who came through the MPH program at Dalla Lana School. Before that, we've had other amazing research coordinators. And then here's my dream team in terms of the advisory group. And then this was interesting because this study actually is, you can't get in it if you're Indigenous. So in terms of like having Indigenous governance of the data, it's actually a non-Indigenous data set, but we wanted to be sure that we were thoughtful about unintentional impacts on Indigenous people in the city. So fortunately, Unity Health Toronto's First Nations, Inuit, and Métis Community Advisory Panel acted as a community advisory panel for the project, and then an amazing group of Indigenous actors. So happy, and hopefully the publication will be out and there's a whole presentation we can do if people are interested. I think we're going to try to do something at Family Medicine Forum, but a 3-armed randomized controlled trial. We used the SANIAS program. We compared it to a brief anti-bias training session that was built on the only brief anti-bias training program that has impactful results, the one designed by Patricia Devine and Will Cox, who were on our team. And we had a number of outcomes that we measured, but the most important one, and the one that we focused on and that we're publishing, were outcomes around the quality of the relationship as assessed by an unidentified standardized patient. So after people had taken the training, we sent in Indigenous actors who we had trained and standardized their scoring on some measurement tools. And you'll see in a minute what we found out. A little bit more about the training. I got to tell this story really fast. So you know about the SANIAS training. I mentioned this brief anti-bias training. If you're interested, have a look at this paper by Devine and Cox. And then the control was we paid for the physicians and nurse practitioners to have clinical training. We made sure that it didn't include any anti-oppression traits. So it had to be bread and butter stuff like how to manage high blood pressure. We did use a number of other measures, pre and post explicit, and we drew on the Indigenous White Implicit Association test that we have developed at Wellbeing House in collaboration with Dr. Christina Klopfer, who nested her PhD thesis in a project. And then here was the unannounced Indigenous standardized patients. So we had these 7 Indigenous actors trained to present a complex patient scenario. And so they all had a disease, an inflammatory disease called ankylosing spondylitis. And we had 2 domains of outcome measures. One was the patient experiences of care, and then one was the clinical standards of care, which focused on assessment of the clinical practice guideline adherence, for pain assessment, and also for renewal of non-steroidal anti-inflammatory medicine. And here's the results. So these are odds ratios. The bolded ones are significant. You'll see wide confidence intervals. But basically, this is a good question to ask, a good, simple, plain language question. Would you recommend this healthcare provider to a friend or family member? I think I like it. I had seen it in the literature for a different study, not Indigenous specific. I think there's probably a lot in there. It powers up really quickly. But what we can see is people that took cultural safety training, either of these 2 evidence-based trainings, were 5 to 7 times more likely to be recommended, to highly recommended to friends or family members compared to the people that had the placebo training. We also developed and piloted and have done some preliminary validity assessment for a relational scale that includes 13 other questions. And you can see here, when we control for the age and gender and previous Indigenous experience, that were also powered up for this assessment scale. We didn't have any statistically significant results for the pain outcomes and instead renewal. We had 58 people complete the study, probably need about 200. So we're thinking, and if anyone's interested, please reach out because we're thinking about the what for this. But we were very pleased to show that you can actually use simulation and hopefully in the way that we're sharing and disseminating the study, we can, as well as the systematic review, we can encourage the field to move towards like tangible outcomes that actually focus on what we want. We focus on the quality of care, both relational and clinical, that has tangible benefits to our community, so our community is going to feel tangibly better. Okay, next story. Here's my half-read script. I promised it. So it's chat's funny because if I was in a room, I'd ask you. So I think in Ontario, I hope people are increasingly used to seeing half-read script. I have a whole drawer full of it. So that's why it's really hard to pretend you're Métis, because the settlers were really good at documenting this. Because instead of when we left treaty, and you'll see in my kin line, actually my treaty relatives left treaty. But this half-read script, the story about it, so this is one of my root maternal ancestors, so probably Marguerite Sauvé's great-grandmother. She was actually part of Papa's Chase's people, and in Edmonton. So the Papa's Chase band actually had a land claim in Edmonton. But actually, she left treaty. And it's interesting because Papa's Chase's people were also called the Edmonton Stragglers. So 30 years ago, when I was in medical school, I went to the archives to find my half-read script. Now you can see it all online. But what's interesting is I was embarrassed about the fact that I had this root ancestor who was an Edmonton straggler. So I kept this script, and I have lots of other Métis relatives. Nobody really out married until like the 30s and 40s. So we just married other Métis and First Nations. But the thing about the Edmonton stragglers now, actually, and some of my Métis historian friends are looking into this more, and this reframing that can be so important, because I was growing up in Ontario too, and prestigious First Nations. I was like, well, who's this Edmonton stragglers band? But one day, my Auntie Maria was sitting at my kitchen table, and I said, have you heard of the Edmonton stragglers? And it's beautiful because she's such a wonderful historian. And she said, yes. And I had been ashamed, but she said, well, those ones came in late to treaty. So those of you that understand the signings of Treaty 6, we were getting started into signing those treaties. So the stragglers were called that in English, but it's actually because they were able to resist treaty signing longer. So she said, oh, those were the ones that were the really good hunters and trappers because they came in late. And then, of course, other people now are studying this group of 84 people, one of whom is one of my root ancestors. Yeah, they're now being celebrated. And I guess they were a little bit resistant even to the Indian agents. So as happened during treaty signing, there was disputes around the land that was offered. It kept getting changed. So finally, my root ancestor and her family just left that treaty. And that piece of paper I showed you before was the half-read script she got. Part of that is just to help people remember, at least on the prairies in my kin lines and my kin states, we're related, right? We're interrelated. First Nations and Métis, of course, there's been subsequent generations life experiences get very different because with half-breed script, my ancestors ended up in the city of Saskatoon, and they could travel there because they weren't restricted by the Indian agent, because they told the Indian agent something and then left treaty. But the one thing that, so these last couple slides here on this part of the story too, are what I actually presented to the Federal Minister of Health. I presented this to the Federal Minister of Health in September. And again, so part of what I'm trying to do here is just truth tell from my perspective. There was a meeting, different quote experts end of quote were invited to talk about the future of public health in Canada. And some of you know I'm very passionate about people getting excluded. And after 3 years of COVID, when I saw how our people in Ontario, our First Nations, Inuit, and Metis relatives who were living in cities were getting excluded from life-saving COVID vaccines at the height of the pandemic, because for some reason our provincial cabinet thought it would be okay to do that. And then, of course, in Ontario, over 80% of the Indigenous population, First Nations, and Inuit, Metis, in urban and related homelands. Yeah, that was a very discriminatory policy, right? But of course, it's quite normalized. So in Ottawa, I get to go to a meeting today on data and anti-Indigenous racism. Of course, the first 2 days don't even talk about urban people, right? The urban people are the last panel that's going to be tomorrow, right? So it's just has real impacts. It has real impacts on people with respect to dying and being hospitalized from COVID. And it has real impacts. Another thing that happened before COVID was, and got worse during COVID, is this whole opioid epidemic. I remember asking Dr. Teresa Tam pre-COVID when I was at Applied Public Health Chair, I said, there was 13 of us applied public health chairs, and we asked her, well, do you have an Aboriginal public health plan, an Indigenous public health plan, a First Nations Inuit Metis public health plan? And she said, well, I'm too busy taking care of the opioid epidemic, right? And we're just like, okay, but what about like how First Nations Inuit and Metis are involved? But we're hidden in that epidemic. So we just have a very, very poor health information system, and there's tons of denial in the federal government about that. So some of the solutions, so this that I've presented, and some of you know I'm really passionate about training more First Nations, Inuit, and Métis health information specialists. If you want to be a health information specialist, please reach out to me. I actually think we need to have alliances within and across distinction-based groups. So I completely agree that we need to know who we are, who we're related to, and where we're from. But these big boxes, these big silos that the feds impose on us actually undermine and cut across who we are and who we're related to. We need to have, be real, right? Let's not pretend that we have a good system when we don't. And then the final one, and the most important one, and what I said to the Federal Minister of Health is, never in my lived experience, never have I heard a traditional teacher, have I heard anything or experienced anything about if a relative moved to the city, we should exclude them, right? When my mom moved to the city of Toronto, I spent my childhood driving across the prairie, visiting my relatives. So yeah, that's something, maybe that happens now, but it's against the natural law of local twins that if a relative moves to a city, we ignore them and we don't help them. But actually, that's the way the Indigenous health policy is unrolling in this country and in this province. So these were the questions I asked. Would it be acceptable to exclude members of any population group in basic public health assessment? And would it be acceptable to exclude members of any other group, right? Like, we don't just say, okay, we're just going to exclude all Irish people, right? Like, we're going to be thinking about the health of people from Europe, but we'll just exclude the Irish. Um, is it acceptable to offer a life-saving vaccine to only one of a constitutionally recognized group? So some of you might know in Manitoba, actually only First Nations got the COVID vaccine on the party, so Metis did not. And then what needs to change in order to advance an Indigenous public health system in which we embed the natural laws of Wokotwin and recognize and care for all our relatives across geography and reject externally imposed colonial definitions of who we are. Okay, so I got two more stories, but what I might do, because we talk about our health counts a fair bit, so maybe what I'll do is save the our health count story for today. But basically, what we're trying to do in our health counts and some of the things I've been working on actually articulating clearly is we're trying to partner with local Indigenous health services, the people that actually provide health and social services to First Nations, Inuit, and Metis living in what I call urban and related homelands. When I have the bandwidth, I try to say First Nations, Inuit, and Metis living in urban and related homelands, because we're not urban, right? I'm Metis first. I'm a Metis woman. I have kin lines that cross the country, and they always have. We always were mobile. It's a myth that if you hear, I'm sure there are. We have such diversity. I'm sure there's some First Peoples that stayed in a territory, but certainly across the prairies, most of us were quite mobile. But we are using Indigenous paradigms and Indigenous methodologies. This isn't participatory action research, right? This is using the Wokotwin of the people, right? But within a quantitative context. So quantitative doesn't have to be colonized, right? And we've all engaged in empirical observation, right? And our empirical observation included not only observing the health and well-being of humans, of the two-legged, but all our relations, all living things in our. Okay, so for those of you that are distressed, there's this story about COVID and how we pivoted our health counts and be gotten at another time. But the last story I want to tell is just a story about the Toronto Birth Centre. If you haven't been there, I hope you will go visit. I had an opportunity to participate and support and co-organize and help fund a 4-day ceremony that we held in Toronto, where we brought the elders and community members and community service providers together to talk about what we needed to do to support reproductive health and well-being in the city of Toronto. It was at the Native Canadian Centre. We also actually talked about health information, and at that meeting, that's where we were reminded by the grandmothers that our midwives had always been the people that kept the longitudinal health databases of our people. And so that was the start of SDMT stepping up to be the data custodians for our Health Counts Toronto. But the story about the Toronto Birth Centre, following that meeting, we had a documentary film that the amazing Rebecca Tobabendung put together in a community report. But the province of Ontario actually was saying that they were going to open 2 birth centres. And we thought maybe one of them would be an Indigenous birth centre in Toronto. We went to the press release, but then as soon as I got there, I could see like this staged family. They didn't look Indigenous at all. And I asked the Premier, I asked Dalton McGuinty, I said, well, what are we going to do about Indigenous birthing needs? Because we have, like, obviously needs. Some of you know I spent a lot of time looking at the health of our infants and their families. And he said, oh, there's already a birth center in Ontario, right? Just like, oh, there's already an Aboriginal health center in Toronto, but we have 88,000 people in Toronto. How could one health center provide primary care for 88,000 people? So yes, a birth center in 6 Nations. So anyways, like the midwives took some of those things. So I just had a little bit of an opportunity to contribute to something much bigger. Sarah Wolf and Shirley Bourgeois led an application, and then they actually amazingly built this world-class health facility. And it's still governed by an Indigenous governance structure. And of course, we see this beautiful Christy Belcourt art in the birth center. And I love to present it when I'm speaking internationally, right? Because it shows that when we use Indigenous models and we support Indigenous people to do things, not only we're not just trying to get equity, we actually can thrive and we can actually lead and create something. So this birth center has had supported the birth of thousands of babies now. And it's actually flipped the demographics of midwifery for everybody in the city of Toronto. So because I've been practicing for a while, and of course I had the huge privilege of delivering babies for the first 10 years of my clinical career, midwifery was usually only something that rich white people could access, right? But of course, the Toronto Birth Center, more than half the babies are Indigenous or racialized babies coming from socioeconomically excluded households. So that's it. I didn't quite get through all the stories. I can work on my timing delivery a little bit, but maybe we'll just see if there's anybody that would like to share in the chat a comment or a question. It looks like I did lose a few participants, but a comment or a question. Is there anything I said that you agreed with? Are there things that you disagreed with? Are there things that you can apply to? Hi, and maybe turn it back to Roy to see if there's any questions.
Thank you, Dr. Smylie. I don't see any questions in the chat or in the Q&A. We are running out of time, though. We've only got a few minutes left. So unless anybody has any last minute questions, I think I can turn it over to Clay, or unless Dr. Smylie has any last final thoughts.
I mean, that's why these things are tricky in the Zoom, right? So I hope that I've said some things that maybe landed in a good way, resonated, inspired. I'm imagining some of the things I said might be a bit different than what people are thinking. Maybe you disagree. The strength will come when we can dialogue, right? And we can share our perspectives. The strength doesn't come from a passive presentation. So I have high expectations of all of you in the audience. And I wish we had a different forum where we had to all sit in a room and actually think hard and share. So maybe we haven't had a chance to do that because I don't see anything in the chat. You have like 2 more minutes just to say you participated in the chat, because that's the process I've been trained in. But yes, thanks so much. And I will turn it over to my friend and our beautiful knowledge keeper, Clayton, to say a few closing.
Well, miigwech, Janet. I just sort of a few comments. I'll start with the birth center. My granddaughter went through the birth center, and she is, and I'll just say as a grandpa, she is the joy of my life. She's everything to me. My children are what she is, like she is the light, right? And the birth center was there, and I just echo, it's just a wonderful center, and it just, and I was praying to find something like that, and we did, and it just happened to be there, because my children, when they came into this world, this was not here, and I wish something like that was, because I went through, long story short, we went through the midwife, all of them, I have 3 children, but I wanted it to be with my people, right? And there was nothing there, and all of this. And there were wonderful services and everything, but again, at this Toronto Birth Center, it's just incredible and amazing what they have done. And I'm so happy that my granddaughter went through that experience. The love and care, that dedication, and to our traditional ways of knowing and being is just incredible. So yeah, thank you for that. And that's the first one. And then also, you know, we're still in this pandemic, right? we're still going through it, and I know a lot of people are tired of it. I know I am. Everything, but I also just want to mention the care that you provided for our people, because the care that you provide, because I had COVID. My whole house got it, and I'll just say this, and which your team and your community, which you did for us, I'll never forget that, because we were pretty sick. We got really sick, my whole house, and when I approached you and I asked you for your help, and it was just incredible, and the care that your team provided for my family, because you took my granddaughter had it, and my wife, and I was really worried about my wife, and it was serious. Like, it was almost to the point where she was almost had to go to the hospital. But I just say this because of the care you gave. Your team came every other day, came and checked up on us and our vitals and everything, and took care of us. And that's what I mean by the work that you're doing in the community. So miigwech, and thank you for everything you do. All right, the hard work you do. Lots of work to be done, and all of that. So with that, I just want to say miigwech to everyone for being here again. So just a closing prayer, and just we invite spirit in us, like you were saying. It's very challenging to do this, because I'd rather all of us be together in a big old circle, and have the energy there and the spirit there. But it is here. So again, I just say miigwech, and thank you, Janet, for your wonderful talk, and as my friend, just just encouragement to you. Just keep going. I know it's not easy. You know what I mean? It's not easy, right? The work you're doing, and all the other people, the people that you work with. So again, I just say miigwech. Thank the ancestors, acknowledge them, and those loving, kind ones. And I ask for the blessings for all of us coming together. And we heard some good words today, and inspiring words. I say miigwech to Janet and her family, to bless her, keep her going strong, and all the people that work with her, and all the people who are working for the people, our people. And I say miigwech. I ask for the blessings. I give thanks to the earth, the sun, the sky, and creation. And I thank the Creator for bringing us together in this virtual circle. All my relations. Miigwech. Thank you, Janet. All right. Lama P, everyone.